Good afternoon and a very warm welcome to you all and thank you so much for attending this, what is planning to be a very interesting discussion around defining recovery in terms of abstinence-based treatment and opiate substitution therapy. As president of ISSUP South Africa, I want to warmly welcome you all and thank our esteemed colleagues for agreeing to present different viewpoints on the topic as described. So two distinct schools of thoughts permeate the discussion around substance use disorder recovery, that of harm reduction or abstinence. While both retain importance in the treatment of substance use disorder, the base of understanding is seen as significantly different. What are the benefits and the challenges of each? How do each impact on the field of substance use disorder intervention? The idea that both can form part of the continuum of care for treatment of substance use disorder is growing internationally, yet most professionals in the field propose one over the other. However, the notion of gradualism might be useful in building this continuum of care and offer greater benefit to those individuals that are navigating their recovery. Please also note that this webinar is provided for informational purposes only and does not constitute medical or treatment advice. The views presented here are those of the speakers and not necessarily those of ISSUP. So we'll jump right into it, and I have the privilege of introducing our first speaker, Dr. Ed Day. Dr. Ed Day is an Associate Professor in Psychiatry, Institute for Mental Health at the University of Birmingham. Dr. Day is the UK government's drug recovery champion. He is also a clinician who has led the orientating of clinical practice towards recovery and has a research interest in recovery support services and mutual aid. He is a clinical reader in addiction psychiatry at the Institute for Mental Health at the University of Birmingham and a consultant psychiatrist with Birmingham and Solihull Mental Health NHS Trust. He's been an expert advisor on addiction issues to Public Health England and the Department for Transport, and is currently the president of the Society for the Study of Addiction in the UK. Dr. Day's research has focused on the broad theme of effective treatment interventions for drug and alcohol dependence. This has involved a combination of projects utilizing medication and psychosocial interventions, projects exploring methods of implementation, research into the organizational factors associated with effective outcomes. In 2008, he set up the MSc program in the treatment of substance misuse at the University of Birmingham and remains active in both teaching at both undergrad and postgraduate levels. Thank you, Dr. Day, and a very warm welcome.
Thank you very much. Let me just hopefully I can share some slides with you now. I must start with an apology, as I was just saying to everyone backstage. I have unfortunately developed COVID over the weekend, so any coughing, spluttering, or sneezing will have to be excused in the next 20 minutes. Hopefully I can get through it okay. Hopefully you can see my slides, so I'll push on. Oh, no, what's happened there? Oh, this is not a good time for that to happen. Let me switch that out. There we go, that's better. Right, so I have this role, as was mentioned in that very long introduction, as UK Government National Recovery Champion. And now my slides are moving. Oh dear, it's not going well.
I will stop the screen sharing momentarily and then resend the notification.
Thank you.
Please bear with us. We shall be with you shortly.
Right, there we go. We're on. Sorry, apologies for that. So the COVID's affecting my computer as well, obviously, which is really worrying. So I have this strange job of UK government recovery champion. So this is a national appointment as a seconded role, and was originally created in 2017. And the reason I mention this is because it casts an interesting perspective on the background to this session. So from what I could gather, the two key roles that this post had to deliver on were, firstly, making sure that the government delivered evidence-based practice for the treatment of drug problems, but secondly, to create greater partnership working in the UK. And one of my great passions is about breaking down this notion that we have a polarized view to treatment. The fact that you have to either be for harm reduction or abstinence. And I'm going to talk to you about the concept of recovery and some of the definitions of recovery, and show you how we've enshrined that in the UK, which hopefully will go some way to showing you that the concept of recovery spans all of these issues, and that polarizing them really doesn't help anyone, especially the people we're trying to care for. So whenever I talk about addiction, I always show this slide to start with, because whether we're talking about drugs, alcohol, behavioral addictions, we can usually think of a spectrum of problems or a spectrum of ways that people engage with substances like, for example, alcohol. So at one end of the spectrum, on the left-hand side of the screen, you've got people that either don't use the substance at all, or engage with it in a purely social, recreational way that enhances their life and causes them no problems. At the other end of the spectrum, you have what would be called dependence, which is the idea that some people, and maybe that's 1 in 20, get a functionally significant impairment that's caused by the substance use, which gets worse and worse as the problem develops. In between, you've got a group of people who may be developing increasing problems but haven't reached the level of dependence, and this group might be thought of as a group that might be going in the wrong direction and can be helped to go back the other way. And because of that, you have to have a continuum of interventions available for you in a system. So the treatment sector is one we're familiar with, but we have to have interventions further upstream, so early intervention, brief interventions, and the sort of educational primary prevention and enhancing health education that would be delivered to the general population. What we're going to focus on today, though, is recovery support, which you'll see is situated after treatment in that sort of linear progression. Now I've got, there we go, slide problem. So I just wanted to give you a brief description of the evolution of the definition of recovery. What do we mean by recovery? Recovery often, certainly by politicians in the UK, is rather lazily seen as the same as being abstinent, whereas that's not at all what recovery means to me or a sort of growing body of people working in the field. So if we think about how that concept evolved, top left-hand corner of the screen, you've got a picture of Benjamin Rush, who was a physician in the United States in the late 1700s, who first wrote about the effects of alcohol on the human body and mind, and the potential remedies for curing the ardent use of spirits on the body and mind. Now, interestingly, his view was that the problem lied with very hard liquor, so spirits, high alcohol content drinks, and that the solution to dealing with it was helping people switch to lower alcohol content drinks such as beer or mead. And you could perhaps think of him in that sense as the first true harm reductionist. As we move along through time, you've then got the in the Victorian era in the UK in the late 19th century, you've got the temperance movement, who very much were a group of people who combined both religious beliefs and a belief in public health and improving the lot of the poor, and who strongly advocated total abstinence from alcohol. That stance was then carried forward into the development of Alcoholics Anonymous in the mid-1930s, who took religious views from and skills from the Oxford movement and turned it into a model that involved total abstinence at its heart. That then was adapted by, and the book there you have, The Disease Concepts of Alcoholism by Jelinek. He described a progressive chronic disease and very much used the principles from Alcoholics Anonymous to describe that. So his treatment strongly recommended that dependence had to be treated with total abstinence. But the interesting change came in the 1970s with the Sobels, who concluded from their research looking at the outcomes of people with alcohol problems that recovery from alcohol dependence didn't necessarily require abstinence, although quite often people did choose that as an outcome. But they showed that controlled drinking was a possible outcome for treatment and was an effective form of result of treatment. So if you think about how more recent definitions of recovery have evolved, on the left-hand side of the screen, you can see those that came from about just over 15 years ago. And all of them refer to abstinence. So abstinence from dependency-producing drugs, abstinence in the Centre for Substance Abuse Treatment one, and the concept of sobriety in the Betty Ford Institute Consensus Panel. So at that point, it was felt that recovery required abstinence, but also improved health, wellness, and quality of life, so other elements as well. But you can see as we move to the right-hand side of the screen, more recent definitions of recovery no longer talk about abstinence. They're much more focused on recovery being an individualized, intentional, dynamic, relational process involving sustained efforts to improve wellness. So no longer is abstinence a be-all and end-all of recovery, but very much wellness, health, and these other factors are the crucial elements. So this is how I talk about recovery in the UK. So I use the best UK definition, which came from the UK Drugs Policy Commission, which said that recovery had 3 elements: control over substance use, problematic substance use. So you'll notice not abstinence, and this would allow someone who's on opiate agonist treatment such as methadone or buprenorphine and not using substances to be in recovery. But recovery isn't just about that. It has to also include maximizing health, physical health and mental well-being, and also this concept of a satisfying and meaningful life. So participation in the rights, roles and responsibilities of society. You can, for example, become abstinent from alcohol problems by never leaving the house, never speaking to anyone, never going on the internet, never phoning anyone, never seeing any alcohol. You wouldn't drink, but you'd have no quality of life whatsoever. So recovery is about much more than just control or abstinence of a substance. It's about all these other elements. And the points at the top are the crucial elements here, that there's no one pathway to recovery. Many people would tell you that recovery is defined by the individual, and that us as professionals don't really have a right to comment whether someone's in recovery or not. But whichever way, when you've got significant dependence, reaching recovery is a process, and it takes time and considerable effort to maintain it. And that means that it needs a lot of aspirations and hope from other people around, and almost invariably involves connection. If you believe, like I do, that the opposite of addiction is connection, it's crucial that what must be involved in the recovery process is not just control over the substance use, but also connecting with a healthy community of other people. In 2011, SAMHSA in the United States tried to develop a working definition that included mental health and addiction recovery. And they talked about these 4 factors: so health, home, purpose in daily living, and community. So you can see that links very strongly with the points I've been making earlier. But it also links to excuse me, I knew I wouldn't be able to get through this without coughing. But it also links to a concept a lot of you might be familiar with, and that's Maslow's hierarchy of needs. So this is the idea that the goal of everyone in life is self-actualization, but none of us can achieve that unless we have our basic needs met first. So physiological needs, food, safety, security, love and belonging, which allows us to build self-esteem and ultimately self-actualization. Well, we can think of this concept applying to addiction very neatly, in that I certainly talk about recovery being that pinnacle of this process of self-actualization, but crucial building blocks on the way are the elements of harm reduction. You can't recover if you're dead. keeping people alive is an absolutely crucial part of the of building this. And we can imagine that different elements of this are very similar to Maslow's original concept, that physiological stabilization of the situation. So having a detox, maybe an example of that. Safe housing, a sense of belonging, and a building of self-esteem and confidence to live a full life. And the idea of one of the really useful concepts that's come through in the last 20 years has been this idea of recovery capital. So this is how I conceptualize recovery, in that what I'm trying to do with any patient that I'm treating, whether they're receiving opiate agonist treatment or whether they're having a detox, I'm trying to build recovery capital irrespective of whether they're aiming for abstinence or control over their substance use. And recovery capital has lots of different elements. Some of them are cited in the individual. So these are things they may possess, food or housing, earnings, but they're also personal characteristics that they have, and their health is one of those elements. But recovery capital also exists at the social level. So bonds with family, community, and social institutions are crucial parts. Recovery supportive relationships are absolutely essential as part of recovery capital. And then beyond that, cultural and community capital are equally important. That the attitudes that the community have to the individual and the people that they spend time with are absolutely essential in building that ongoing recovery experience. Now we can start measuring some of these concepts. So in the middle here you have Scheibe and Best's assessment of recovery capital instrument, which measures different elements of personal and social capital. And on the right you have David Best's RecCap tool, which is an electronic version of that captures this information by questioning the individual and shows how someone's progressing in each of these areas in a visual form. And the final conceptual point I just wanted to mention was this. So John Kelly is one of the leading thinkers in this area, and he has written this very interesting paper about talking about a biaxial formulation of the recovery construct. So he takes as his lead from this that the idea that Griffith Edwards had originally with alcohol dependence was that it had two dimensions. It had the actual concept of being addicted, and it also had the problems that the use of alcohol causes. And this is very similar, that you can think of addiction remission and recovery capital going hand in hand in this process. So as John says, recovery is a dynamic process characterized by increasingly stable remission, resulting in and supported by increased recovery capital and enhanced quality of life. So the dimension he uses is you notice addiction remission, not just abstinence, but however the person defines that control over their substance use. And it separates that's increasingly stable remission from developing recovery capital. So you don't have to be abstinent before you can focus on the recovery capital, and that one or each will have a reciprocal effect on the other. Building recovery capital is more likely to support the person moving towards remission and possibly abstinence if that is their choice. Now, how does this play out in the UK at the moment? Well, this is the diagram I show to lots of people. This is the model we're trying to build of our treatment services. So this is a recovery orientated system of care, and this acknowledges many different pathways in the journey to recovery. And I apologize for the fact that I've only got two dimensions to work with here, because this is rather misleading that this is a nice linear process from the left-hand screen, left-hand side of the screen to the right. But work with me on this. So there are at least three pathways to this. The first is that the person may not choose to access any treatment services. So that, often known as natural recovery, certainly occurs, often with lesser degrees of addiction severity. And also people would access mutual aid groups, the 12-step fellowship, smart recovery, whatever, and never come anywhere near treatment services. But in terms of treatment services, you have on the left-hand side of the screen in green, you have the more professionally driven part, which is the acute care model that engages people, helps them change their behavior, and then hopefully gives them tools to prevent relapse. But they then get discharged from that. And supporting the ongoing maintenance of recovery is this whole world of what I would call recovery support services. And this is an emerging science in this area. Of each of these different elements, as I'll just briefly show you, has an evidence base around it now to support recovery. And in between, you've got those two different elements of assertive linkage to the recovery community and post-treatment monitoring and support. So in the UK at the moment, we have a lot of exciting new innovations in terms of the treatment sector, not least in the center of the screen, depot buprenorphine, which is I've been involved in a trial of and have given to lots of people in the last 3 years, and possibly is quite a game changer for opiate dependence. But alongside that, we're now demanding recovery support services. So these are services that could be professionally led or could be entirely led by people with lived experience, or a combination of both, most usually, and carry out each of those different elements that I'll just briefly mention. So recovery checkups are the idea that you don't just discharge someone once they go into remission, once they stop or control their substance use, but you keep in touch with them in a structured way. Simple, cheap ways like phoning them are often the most effective, but obviously new technologies like smartphone apps are also possible. And this is a structured way of checking in, checking whether they're still on task. If they're not, you can bring them back into treatment. If they are, you can encourage them and help them to set goals and continue their care. And there's a good evidence base emerging for the effectiveness of these relatively brief but powerful interventions. A second concept is recovery housing. So this is from the States, where you have a structured 4-tier system of recovery housing with different levels of intervention. The two groups I'm particularly interested in are the first two there. So these are houses where people are supported by other people in recovery to maintain their often abstinence, but also to get out and to link into wider recovery supports and get into work. I've recently developed this, which is a collegiate recovery program. These are very big in the United States. So this is helping university students to maintain abstinence in a quite sort of toxic environment for recovery on a university campus, with the belief strongly that getting a university degree might be one of the most powerful forms of recovery capital that you could get. And then these are being described in the States, and certainly we have them in the UK, that recovery community centres are places where all these different elements of recovery support are brought together, sometimes with the treatment service as well, often in the best model, but certainly as a sort of one-stop shop for getting support for people in the community. And underlying all of this is the power of lived experience. And I described sort of 3 levels of lived experience in our services. So we have people that volunteer that might still be using the service, but can act as advocates for their peers. You have peer support workers who are perhaps in early recovery and offering support, particularly to link people that haven't made treatment into treatment. And then we have this role of the recovery coach. So this is someone with lived experience who's also trained to act as a coach to help people either navigate through the system or to navigate through the process of recovery after leaving a treatment system. And underlying all of this, whether you follow the 12 steps on the left-hand side of the screen or a more sort of scientifically driven version, i.e. the 5 Ways to Wellbeing, which was produced by the university, by the UK government, both of these processes have a strong element of helping other people, connecting with others and giving back to other people. And this is why people with lived experience are really the powerhouse of the recovery movement in the UK. So to finish up, I've given you lots of different ways of looking at recovery. I've tried to persuade you that recovery is not just about abstinence. In fact, it doesn't have to be about abstinence at all. What it definitely has to be about is about things above and beyond controlling substance use. If you just focus on the substance use, you're not talking about recovery. But this recovery model has a lot of limitations, and here's a couple of them. What's not clear is which health improvements are mandatory to be considered in recovery. So is a person in recovery if they don't follow all the dietary guidelines for best, maintaining stable weight or reducing weight? What if a person carries on smoking cigarettes? Does that count as recovery? Does citizenship mean just gainful employment, paying taxes, or do you have to, as implied in some of the American definitions, go beyond that and work towards the betterment of one's community? Because the problem with some of these things, as people rightly say, is that we're expecting more of people to be in recovery than are expected of our fellow citizens that have never had an addiction problem at all. And this is an important concept to consider, because to really enshrine this process, and in any healthcare system, you need to be able to measure it to say whether it's been achieved. And until we work out these concepts, we won't be able to truly measure and capture the impact of different interventions on building recovery capital. So at that point, just before my voice fails, I'll stop and I'll hand back to the chair.
Thank you so much, Dr. Day. That was extremely interesting, and thank you for that wonderful insight into the global overview of recovery. A lot of very interesting ideas have sort of come out of that. And I think, really for me, what the most pertinent thing is that, it's not about what we feel is the best way forward. It really is about focusing on what the individuals themselves need in terms of assisting them in their process of well-being. So thank you so much for that. Really do appreciate it. Just a reminder to all of the attendees, we will be having a Q&A session a little bit later. So please feel free to add your questions to the question box at the end, and we will deal with them during the Q&A session towards the end. So thank you, Dr. Day, for giving us that global overview, and it's interesting to see what is happening in the rest of the world. I am going to now introduce our next speaker, Dr. Andrew Scheibe, who is joining us and talking to us about OST and the regional perspectives here in South Africa. Dr. Scheibe is a medical doctor by training who works in harm reduction, research programs and policy in South Africa and the region. His work focuses on the intersections between infectious diseases, determinants of health, drugs and rights. He works as an independent consultant and is also a technical advisor for TB HIV care, and is a researcher at the University of Pretoria's Department of Family Medicine and a visiting professor at the Urban Future Center at the Durban University of Technology. Thank you, Dr. Scheibe. We look forward to your presentation.
Great, thank you. I'm just waiting to receive the invitation to share my screen. I think the scene has been set for quite a lot of the concepts that I was going to cover. So thank you very much, Dr. Day. And I think, just to let you know, I'm going to be spending a bit more time on stigma and why that's so important in the work that we do, and people understand its implications on the health and well-being of people who living with a drug dependence, and then speak a little bit more around opioid substitution therapy, and then just end with some concluding thoughts. So most of my work comes from the field of infectious diseases, where a lot of the understanding of the intersections of stigma and its impact on individuals has really come to the fore. And you'll see in this quite complex diagram that I've pulled out comes from the most recent World Health Organization interventions for key populations, and it's their guidelines on HIV, viral hepatitis, and STIs. And what it really just tries to show is when we're ultimately looking at the health impacts that affect individuals, it's not just the behaviors themselves, and they shouldn't be seen in isolation, but very important for people engaged in criminalized activities, which drugs are in South Africa, has a huge impact on stigma, because stigma links to people's ability to become employed, income generation, their likelihood to experience violence, which in fact then disempowers them and makes them less likely to be aware and have access to accurate information and also access to appropriate services. And we know that among people who use drugs, particularly those drugs that are viewed slightly different to other substances, so for example, people who might use heroin or methamphetamine, it's viewed quite differently to people who might use cannabis or alcohol or even ayahuasca and some of the psychostimulants that are currently trending in many places. But stigma is so pervasive in relation to drug use that it's almost universal in the experience of people who use drugs. And that means this has such a dramatic impact on the way that they navigate through the health and social service system and also their experience. And we need to be really aware of how disempowering language can be. and also the words which we use, things like addiction, things like recovery, things like disorder, they are really, really loaded terms that have lots of often negative consequences for people. And I would just like to draw the attention to some of the language guidance that's provided by the International Network of People Who Use Drugs, so that the terminology, the framing, our understanding, our conceptualization of substance use and substance use conditions is framed in a way that is person-centric, is non-judgmental, strengths-based, and is respectful of alternatives. And this is important when it comes to this concept of recovery, because often it's linked to a significant pathology or perceived pathology. And I think what else is often important is for us to take a step back and just reflect when we're engaging with our clients or as managers of programs, you know, whose goal and whose intentions are we really looking to foresee? Are they our own, which are often loaded by morals and perspectives, particularly around drug use? Or are we really supporting people making their own informed choices around what they choose to put in their bodies and how much of the consequences are actually linked to other things that we're not paying attention to? So harm reduction is a concept, just to remind people, there's often a lot of misunderstanding. It's a set of policies, programs, and practices that aim to minimize the negative health, social, and legal impacts associated with drug use, drug policies, and laws. It's important to note that it's an approach that's founded in justice and human rights, and really it focuses on positive change and working with people without judgment, coercion without discrimination, and really not requiring people to stop as a precondition of support, which is often contrary to alternative approaches. It helps to also think of harm reduction in relation to ethics, particularly medical ethics, how it focuses on our humanity, on humanism. It focuses on doing good. It focuses on reducing harms, which links to non-maleficence, to not doing harm, which often only an abstinence focus can do, particularly increasing likelihood of overdose or other things, or exclusion. It tries to maximize the intervention options available to people. There's a strong focus on individualism, which links to this concept of autonomy. There is an integral component of involving people who use drugs in this process, which links to this idea of justice, because often, because people have been engaged in an illegal practice, they're often morally viewed and are ignored and are disempowered. There is this important concept of incrementalism, which means you focus on priority issues now to keep people alive before moving on to other things that might be affecting people. It's very pragmatic, and there's this idea of accountability without termination. And this concept, which was mentioned at the beginning of gradualism, is really synonymous with incrementalism. It's a principle of harm reduction. Now, what is the issue that we're focusing on particularly is in relation to heroin, which is the most widely used opioid in Southern Africa. It's the main active ingredient in nyalpe, wunga, unga, and pinch. It is usually inhaled or foiled, but is often smoked and increasingly injected. And we know that opioid dependence is a chronic condition with high premature mortality. We also know that abstinence-based approaches are very ineffective. This is some data from Cape Town, the largest program that's a community-based abstinence-centric program called Matrix. And this just shows you how poorly it performs in relation to people with methamphetamine use conditions, as well as heroin. You'll see that this is only within a 2-month period. Less than 7% of people with opioid dependence stay within an abstinence-based program. That has nothing to say with the impacts on their well-being or health, just keeping them engaged and interested. It really doesn't align with what people need. So we know in terms of opioid dependence, the gold standard is opioid substitution therapy maintenance. This involves the provision of an opioid agonist medication, usually methadone or buprenorphine. It's provided at an appropriate dose for as long as a person requires it by a trained healthcare provider with access to voluntary psychosocial services. While this is the gold standard treatment for opioid dependence, it is also a very core component of harm reduction related to opioid use. These are some of the guidance that exist from World Health Organization, United Nations Office on Drugs and Crime, as well as other agencies that show how people who use opioids should be involved in these processes. Why are we recommending opioid substitution therapy? It's because it saves lives. It halves all-cause mortality among people with opioid dependence, as well as drug-related mortality. It halves HIV and hepatitis C infection risk, largely because of reduced injecting frequency. It improves overall physical and mental health. It reduces crime and also enhances social integration. Broadly, the process for OST involves some kind of assessment, the induction of a person into the process, up titration to an appropriate dose, and then maintenance. It is important that people have an ongoing access to psychosocial services as well as harm reduction. We know that most people who continue with opioid dependence have ongoing use over many periods of time, and it is important that they have access to the materials to keep them alive and to prevent infections and to minimize harm. So in terms of this maintenance period, it's often that people don't get appropriate doses of their agonist medication, and that's often a main cause of why there is also current illicit opioid use. So as part of the maintenance period, it involves regular check-ins, assessment of treatment plans, assessing other substance use in a neutral, non-judgmental approach, help people to identify their goals for those substances, also to assess ongoing risk of infectious diseases, and also cardiac health if they're at high doses of methadone. These are some of the examples of services that should be provided to people while they are still on opioid substitution therapy. So people who inject opioids should have access to sterile injecting equipment, condoms, lubricant, naloxone to treat overdose. I'm just also giving some insights into why it's important for people working in primary care settings around OST, because it really is a primary care condition. It should be managed at the primary care level with access to specialists to support people with severe comorbid mental health conditions, people that might not be tolerating one medication or require appropriate doses. And knowing, particularly people who are young, there's no contraindication to OST, but it's better provided that services through a specialist. Here are some principles of quality, is that goals should be individualized. Rarely you heard from the previous talk around recovery, but the same applies for actually any medical or biomedical intervention, and also social intervention. We really should be aiming at improving people's well-being and the management of their dependence or their use disorder, not whether or not they're using the drug or not. It's important that there's service in a non-judgmental and therapeutic setting. For OST, it must be maintenance. There's a lot of misconception in South Africa and the region that providing people with low-dose opioid medication for a couple of weeks is OST maintenance. It is absolutely not. OST is appropriate dose maintenance for as long as someone requires it. People who receive suboptimal dosing are more likely to continue with illicit use and to exit their services earlier. And I've mentioned before to really remember that the goal of OST is not abstinence. Some people might choose abstinence, and it might be the goal that many of them achieve. Just a note on methadone, it is a dangerous medication in overdose, but always remember people with opioid dependence have tolerance. They've been using it for a significant period of time. The mortality associated with methadone and as part of an OST program is particularly early on, and also there should be concern of a risk of overdose if there's concurrent administration of other medications which are depressants, particularly alcohol or benzodiazepines, And there's a particular elevated risk when people stop OST, either if that's after detoxification or incarceration, or after going through an abstinence-based program, because of the loss of tolerance. It's important to ensure that people who are opioid naive do not have access to methadone, and there's often a concern of diversion, but in many cases that really points to an inadequate access to methadone and OST, because very few people would choose methadone as their source of medication or substance for either to manage trauma, manage pain, or for pleasure. Urine drug testing as part of OST, it's not essential. It's actually can often be used in a punitive manner and can negatively affect the relationship between client and service provider. So if it is used, it's really important that it enhances the quality of care and should never be used in a punitive manner. As mentioned, the fundamental principle of OST, it's a maintenance program, so we're supporting people over a long period of time. And if it is discontinued, it should be done over a long period of time, and the person should be aware of the risks and they should be supported. The access to psychosocial services really should be intensified over that period. And if people are not doing well, their dose should be up titrated and the tapering made longer as necessary. In closing, a couple things to remember. Opioid substitution therapy is essential. It should be and is considered by the World Health Organization as one of our critical health interventions. It reduces overdose death, reduces illicit opioid use, reduces transmission of infectious disease, and improves health and well-being. The medications need to be provided at an appropriate dose. It is a maintenance therapy. We really need to increase its access in South Africa and the region, and really improved well-being, not abstinence, is the focus of OST. 5 things we should all be doing is follow evidence-based practice, teach your community about OST, demand that methadone is placed on the essential medicines list for maintenance at the primary care level, demand that your departments of social development and health and your local municipality fund OST as well as part of their response to problematic substance use, and really start demanding that it gets put onto private medical aid. Thank you.
Thank you so much, Dr. Scheibe. What a fantastically interesting presentation, and how it tied in with Dr. Date's presentation. You know, I think really a couple of things really stood out for me, and the one is that, you know, when we are looking at interventions for substance use disorder within the country, we need to focus on the enhancement of well-being rather than the punitive side of things. And I think the OST really ties well into that. So thank you very, very much for that. And also this idea of the incrementalism and the gradualism, and that, you know, it's not one or the other that we need to focus on, but how do they actually tie in together? And as you said in your presentation, at the end of the day, a lot of people will choose a different path for themselves, and it's not really up to us to say, well, that's not the correct way to do it, but we need to be supportive and try and assist as far as we can. Thank you very much for that fantastically interesting presentation. I'm going to move on to our next presenter, Mr. Subendran Naidu. Subendran Naidu is an independent contract IT lecturer at Rosebank College, where he facilitates computer architecture and networking modules. A social worker in private practice specializing in grief, bereavement, addictions, traumas, and palliative care counselling. He's a master's student at the University of Johannesburg, completing his master's degree in clinical social work. A yoga teacher facilitating yoga courses, a volunteer at the Art of Living, an international association for human values, facilitating courses in yoga, breath work, and meditation, and an adult with alcohol use disorder in sustained remission for more than 14 years, and volunteering in mentoring others in recovery from alcoholism. Mr. Naidu, thank you so much for agreeing to present for us today in that what seems to be an extremely busy schedule. So thank you. We look forward to your presentation.
Thank you. Good afternoon, everyone. So I'm speaking about the dynamics of alcohol addiction recovery. So in my presentation, I'm going to look at abstinence and in particular a 12-step program. I'm going to offer a perspective on how the 12-step program works and then make some recommendations on maintaining recovery. So in terms of abstinence, I'm going to just add a little more to abstinence in saying that, abstinence is not just refraining from the substance. Abstinence also includes abstaining from the words, thoughts, actions, behaviors that prompts substance use. So what is it that is, the underlying cause? Abstaining from those thought patterns, those behavioral patterns that cause us to pick up a substance. So in terms of 12-step programs now, why are they so effective? Research indicates that they are as effective as other therapeutic modalities. And, in therapy, we try to create an environment that is a safe space. It's a non-judgmental space. We respect the individual. And 12-step programs are generally run by amateurs, so it's a peer support system. And people are in a space where, they feel loved, they feel respected, they feel that they can relate and identify to other people that are part of this process. So it also offers them a structure, a problem-solving structure that they can use to solve their problems. They have access to role models or sponsors, other people that have made progress in the recovery program. They mentor each other. And then also it's readily accessible. So no matter where you are in the world, you can attend an AA meeting both face-to-face and online. So I'm going to go through the 12-step process now. And I invite you to apply your various lenses, whether you're a professional or you peer support, and think about these steps in terms of, what does my professional training teach me? What does my personal experience illustrate? So consider it from your perspective, from your lens. The 12 steps, there isn't a guideline book published by Alcoholics Anonymous that says that it must be done in this particular way. It must be taken by the individual and it must be customized so that it can make sense to the individual. So as professionals or as peer support, we can apply these 12 steps using our existing forms of treatment. So the first step says there's a problem. My drinking is the problem, and I'll use this throughout the presentation. My drinking is the problem. I need help. And to get to this point, it is generally found enough pain and suffering gets the person to that point. Alternatively, intervention, family, attendance of AA meetings, and from a therapeutic setting, motivational interviewing has been found effective to, convince the person that I do have a problem. So step one is I have a problem. Step two, who can help me with this problem? So in AA, they describe a higher power, and the person is left to define this higher power. There's a misconception that it's a spiritual organization or it's a religious program. I just see it as a problem-solving process, okay, the 12 steps. So the person gets to define, is this solution, who is going to help me? Is it going to be God? Is it going to be my higher self? Will time solve my problem? Will the church solve my problem? Will AA solve my problem? So the person gets to define what is going to help me get through this problem. And it's going to be unique for the individual. In step three, I take the problem and I hand it over to the solution. And I say to myself, okay, this drinking problem of mine is no longer my problem. I'm going to take my drinking problem and hand it over to God as I understand God. In step 4, and this is the crux of this 12-step process, it's to get a true understanding of who I am as an individual. And many people describe this step as it being, you know, as being reborn. It's like I'm a child again, and I get to discover, who am I? Really, who am I? What works for me as an individual? What does not work for me as an individual? So step 4 is about going back and identifying, okay, I cannot talk to a female. When I have alcohol, I can talk to a female or to a male, a member of the opposite sex. When my feelings are hurt, I cannot express myself. So what do? I take a drink and then I can express myself. So it's to identify what are those things, or in which situations did I find that I needed alcohol to do for me what I could not do for myself. In step 5, I'm going to tell other people about what I've discovered about myself from my drinking problem. So here it's a process of storytelling, and this is what happens at AA meetings. They keep relating their experiences about what it was like, what happened, and what it is like now. And it's through retelling their stories that they are able to, you know, discover, who am I again? What is working for me? And also to acknowledge who I am as an individual. You'll also see I've also got different parts of self that I'm referring to in the slides. So step 6 now will say, okay, well, I found out that, you know, I'm non-confrontational, and let's take my drinking, for example. The reason I was not able to quit drinking was because I was being dishonest with myself. So this is a defect of my character. I acted as though I can drink like other people, and I kept drinking to prove that I was not an alcoholic. Now, the term alcoholic I'm using is a person that has lost the ability to control their drinking. So having identified that I'm being dishonest with myself, I need to do, this is a defect of my character. Okay, in certain situations, I lie to myself. So in step 7, it says, okay, well, practice the exact opposite of what you have done. So if I'm being dishonest with myself, I need to be honest with myself going forward. So if I need to say, okay, I am an alcoholic, I cannot drink like other people, I need to do something about my problem. So that's where step 7 is coming in. Step 8 says my drinking did not just affect, I was not the only person that suffered and harm due to my drinking. I affected a number of other people. It was my family, my friends, my work colleagues, etc. And now that I'm aware that my drinking has affected all of these other people, I need to change my relationship and make amends. And step 9 goes on to say, okay, well, let's now learn from my mistakes with my relationships with other people. Where possible, I will change the dynamics of the relationship. And where it's not possible, there will be other opportunities for me to not practice those negative behaviors. If I lied, if I cheated, if I stole from other people, whatever those behaviors were, if I was obnoxious and arrogant, I was insensitive, whatever those behaviors were that were not working for me in those previous relationships, I get an opportunity now to practice this in new relationships. And also step 9 is not just about saying I'm sorry. It's about not repeating the old behaviors that caused harm to other people. And step 10 is, you know, going back and reflecting on myself on a continuous basis. Am I the same person I was yesterday, last week, a month before that, last year? Is there something that's happening? Is there some sort of change that's happening within me? Am I getting better at this process of not pointing fingers at other people, taking responsibility for my thoughts, my actions, my behaviors? Has something changed? Has my awareness heightened? And step 11 then goes on to say, well, okay, if you're going to take your problems and hand it to your solution, you better have a good relationship with that solution. So if I've taken my drinking problem and handed it over to God, I need to ensure that I have a good relationship with God. And how do I facilitate this relationship? How do I improve? How do I grow in this relationship with my higher power or with God of my understanding? I would use prayer, meditation, spend more time with this higher power or the solution. And then if things don't go according to plan, what I can do is I can not shoot the messenger. Previously, people would report getting angry, anxious, right? And taking out their frustrations on other people. Now I get to say, okay, why did God send me this person to speak to me in this way or to present me with such news? So if I seek God in the situation or practicing the solution in everything that is happening, whether it is life circumstances or whether it is thoughts, illness, whatever is happening with me as an individual, if I can see some higher purpose to it, some higher power being behind it, then I'm improving my relationship with a higher power, and I'm working towards, becoming more self-sufficient. And then finally, we move into helping others, and it's been mentioned before. The person gets a sense of belonging. It boosts their self-esteem. So if I am able to arrest my problem with drinking by handing over my problem to a solution to a higher power, okay, then chances are if it worked for my drinking problem, maybe it will work for my problem with nicotine, caffeine, food, sex, relationships, money, any other problems that I might face. I could go through exactly the same process. And this eventually, and this process of helping others, they call it 12-stepping in Alcoholics Anonymous. It's where you are doing something for another person, expecting absolutely nothing in return. So we do it for altruistic reasons. Many of the alcoholics report that there was always some motivation behind them having a relationship or having an interaction with another person, and it was self-centered. Now, step 12 enables the person to become selfless, where they're thinking more about the other person's well-being rather than their own. So now that I've got sober, how do I maintain my sobriety? In Alcoholics Anonymous, they make the following suggestions. Firstly, live for 24 hours. They say, just quit for today. I don't have to give up alcohol for the rest of my life. I just have to stay away from the first drink just for today. Regular meeting attendance. Initially, it's recommended that you do as many meetings as you can in early recovery for the first couple of months. Thereafter, according to your lifestyle and your composition, you would decide what's going to work for you. But generally, the norm is for sustained recovery, you need to attend at least one meeting per week. You get yourself a sponsor or a sober buddy, some person that has been through this program before and some person that can guide you, you can bounce ideas off. You work this 12-step program, and the most effective way to work the 12-step program is to sponsor others, is to take others through this program. Where by taking others through the program, you are also reinforcing your own process of change. And then to educate yourself, be informed, read the literature. Now, SADOC says, in order for us to sustain recovery, they make 3 important points here. If you've got other comorbidities, make sure that it is treated, it is addressed, right? So like antisocial personality disorder, it needs to be addressed by professionals. If you have good stability in your life, that means you have good quality social support networks, you have a job, you have good family relationships, you are generally more likely to maintain your recovery, to maintain your sobriety. And then the rehabilitation process, once you've attended a treatment center or a treatment facility, or even if you've just walked into Alcoholics Anonymous, right? We need to maintain those levels of motivation. And in AA, they speak, for example, about remembering your last drunk. So I never ever want to go back there again. So by constant exposure, at least once a week, you are going to reinforce your reasons for wanting to maintain your sobriety. Sober lifestyle adjustments, you know, they speak about if you sit in a barber shop long enough, you're going to get a haircut. So if you've quit drinking, why would you want to hang around bars, for example? If you hang around bars where people are drinking, eventually you're going to pick up a drink. If you don't drink, why go to a bar? Go to a coffee shop. Okay, and then be aware of the strategies that that can be used to prevent relapse. So we need to have that awareness that I'm not cured. Once I've gone through this recovery program, it's a lifelong chronic condition that I face. And recovery then becomes an intuitive process. They say, you know, initially you need to work the steps, and then after a while the steps works you. Researchers in South Africa came across the following, or make the following recommendations for sustained recovery. There needs to be a psychic change, right? So the person themselves needs to undergo this psychic change. There needs to be support from family, friends, other support groups. We need to have a plan to say, okay, if I'm faced with a craving, how do I plan to deal with that craving? Okay, if there's going to be a problem, previously I used to pick up a drink. Now what is it that I'm going to do? I'm going to pick up the phone. I'm going to go for a walk. I'm going to listen to some music. So I need to have strategies to deal with my cravings, and then avoid managing or avoiding those risky situations. Go to the coffee shop, not to the bar. Okay, so it's about maintaining that awareness. So in summary, you know, sustained recovery is about identifying and growing your personal resources, your environmental resources, and then looking at maintaining good quality and positive interactions between your personal and your environmental resources. And then to conclude, some recommendations. There's no one size fits all. It needs to be customized to the individual. And, you know, we need to look at it from the client's perspective. What's going to best serve them, and then work with each other. The language that we used, I used a number of what might consider negative terms, like calling the person an alcoholic, right? But it's context-based. One person might view being called an alcoholic as a derogatory term or a negative term, and another person might view it as an empowering term. Okay, so the language of recovery makes a difference, and the language to the person, to the actual individual, is what's of critical importance here. Recovery is contingent on taking the medication, be it the 12 steps, be it a substance, be it a support system, whatever it is, the person needs to participate in their own recovery, take ownership for their recovery, right? So compliance might be an issue here. Recovery is a process, and slips are part of this process. Very often people think, if I've taken a drink after coming out of rehab or after being sober for a year or 2 years, then I might as well just give it up, okay? But this, we need to get the word out there that it's part of the recovery process. So it's not a failure on the individual's part, and most often the person can go back, look at what was doing, what preceded that relapse, and then learn from that was a possible trigger So going forward, what is it that I can do? What is my coping strategies going forward? And it's a deliberate, planned process that involves a multidisciplinary team that includes your health, wealth, spiritual, social services, both professionals and peers. Thank you. I am done.
Thank you so much, Mr. Naidu, for that perspective from the NA perspective. Very, very interesting. And I think, you know, one thing that really stands out for me is what you mentioned earlier on, that term awareness, and how the individual needs to be more mindful about what is necessary for their process in terms of dealing with their substance use disorder. And I think that that's something that we need to remember as professionals in the field, is that often it's about what the client or the service user feels is going to be more effective. So at this point, we're going to play a couple of videos, and really it's this part of the webinar is entitled "The Story on the Ground," and they really are voices of recovery. So I'll hand it over. Thank you.
Recovery to me means growing beyond your destructive habits and gaining control of your life again. And in order to do that, recovery needs to be an active thing. It's an ongoing process. No matter how long you stay sober, you are working on your recovery on a daily basis. And so recovery is action, recovery is ongoing, and recovery is actually achievable. But one needs to grow beyond what once was to what one wants to work towards. And that's obviously living a balanced life.
Wow. I don't even know where to start, because, you know, I could talk about this all day. I have my life back, and it makes me proud. That's why I'm not embarrassed to talk about my experiences with alcohol and drugs. I have my life back. I have my dignity back. I have my family back. We are all happy. We are together as a family, and that is one of the best achievements of my life.
What recovery means to me is that you are no longer in prison, that you are in touch with reality again, that you do the normal things normal people does, that you no longer have these fierce and hopeless feelings. How will you get your substances? Where will you get the money from? That you are having the trust of friends and family again, that you have self-confidence, that you can work again, that you can get the normal daily things.
Recovery means to me getting my life back, getting my family back, having time with my children, being awake and in the moment, able to experience life in every diversity without being dulled, without being led by this monster of addiction. The main thing that helped me on my journey to recovery was definitely my relationship with God. I think that's one of the most crucial things. It was also just making the necessary changes that I needed to make. You know, there were certain things like my triggers, you know, people, places, things, feelings, thoughts, memories. Learning how to deal with these cues also helped me to maintain my sobriety, staying accountable as well. I think that's so important. You know, one-on-one accountability, peer support groups, you know, recovery groups, those kind of things also definitely helped me and is still helping me to this day. And so I would definitely say those are the things or the pillars that I have in place, you know, taking my sobriety one day at a time, just focusing and working on this thing each and every single day of my life.
What helped me on my journey was the support of my loving family and friends, and then also the skilled and well-equipped people in rehab that look after you and sometimes help you with withdrawal symptoms, the medication, the right medication that you get from your doctor, as this social workers and the occupational therapist. And the program is in place, and there's so many people, professionals that can help you in this journey.
What helped you on your journey to change your life? Well, firstly of all, I had to make a choice for myself. That was the first step on a long journey, as well as support from people who are around me, who loved me, although initially that circle is very, very small. One's ashamed, one's hurt, you're scared for what's lying ahead. But yeah, to take that first step, that was my first step. And everything I learned at the sessions there, as well as our support group who meets once every 2 weeks, been a tremendous help and support. And that definitely helped me a lot on my road.
The advice I would give to somebody who wants to go through this journey is that one needs to get real with themselves about their problem, about their addiction. I think once one gets real, once you get serious about it, that's when the healing process can actually start. Once one acknowledges that there's a problem, that is when one can now look for solutions, for things that may, help a person to grow beyond these destructive habits. And so I think, that's the most important thing. That's the first step. When people come to me and say, Cody, I want to stop, and I ask them, are you willing to do everything that it will take in order for you to grow beyond this thing? And so I think it's about getting really serious and getting really active about one's personal journey in recovery.
The advice that I want to give you, you are not alone. Please, at the moment when you find that you realize you are in danger with your emotional and physical health, please seek for help. Go to a social worker. Start to talk to someone that you can trust, and that is when your recovery starts.
First of all, take that first step. You're going to be scared, you're going to be afraid, you're going to be ashamed. Your brain's going to tell you don't do it, or going to lie to you. You're going to lie to yourself, you're going to believe yourself, but somewhere deep inside, you know that you're not on the right path. You know you can't continue like this. Take that first step. Admit you've got a problem. Seek help. No one's going to judge you. And very, very important, start by wanting to do this for yourself, for no one else. Important.
Man, I've achieved so much since I've stopped drinking and smoking. In the past 7 years, I've made movies. I have been on TV countless times. And that was a dream. That was my dream that I felt I could not achieve because the substances had stolen my dreams. I have my dreams back. The day I walked into a rehab, very high, drunk, I knew I needed help, and I could not take no for an answer. There's no magic pill that they gave me. I made the decision to quit, but they gave me all the guidance, and you know, the education they gave me, it helps me to sustain my sobriety. Everything that they taught me, I can use in my daily life.
The important message that I would like to share is this: addiction is not the end. It is only a fork in the road. And so one needs to get to that place where they want it for themselves. If you don't want it, people can want it for you, but if you don't want it, you're not necessarily going to work hard enough to get it, you know? And getting free from addiction is only the first thing, you know? Staying free is what's going to require diligence. And so one needs to work each and every single day. It's not going to play out perfectly, but if one is committed and if one is diligent and if you have the right structures in place, God, family, support, those kind of things, it helps to make the journey a bit more easier. And so I want to encourage people, addiction doesn't have to have the last say in your life.
The message that I want to give you is that recovery doesn't ask for gender, it doesn't ask for financial status, it doesn't ask for race. It can happen to anyone. And please try to trust someone. Make the effort to go to see somebody that is a professional, and ask for help from maybe your parents, your children, your siblings. This is a process, it's a journey, and it is a journey that you invest in. That
I would advise people to start taking charge, to start taking their lives back from this thief called alcohol, from this thief called drugs.
An important message. Again, take the journey slow. You're going to be impatient. You're going to want results immediately. Your brain's then going to tell you this has to be sorted out. You're going to have difficult days. They're going to feel long. They're going to feel forever. I was doing the outpatient program, which I think might be a bit more difficult. It's not necessarily for everybody, but at least try, go for it. And remember, you'll get through. You'll get through it. Whatever is important to you, that smile in your children, the light in their eyes, the being in the moment, being sober, being able to support somebody else, being able to give advice, and guide people who you see are on the wrong path, warning other people. But first you have to go through this little bit of a bumpy road. So yes, it's not easy. Yes, there's going to be bad days. There's also going to be good days. And eventually you'll get through it. You'll smile and you'll get your life back. That's the most important part. Go for it. You've got nothing else to lose. Thank you.
My name is Koketso Mukobani. I'm from Senput, and I'm the community linkage officer for the organization. Recovery to me means life. It means that you are able to live without any judgment, whereby your overall health has improved, whereby you don't need any illicit substance for you to function. What helped me on my journey to recovery? There are different interventions that help me in my life. the interventions are from the harm reduction philosophy, whereby I attended CAC sessions, which are community advisory groups, whereby we get together as those with lived and living experience, and we share our daily challenges and our triggers, whereby what I may be going through, the other person might have went through in the past, and he's able to tell me how he navigated through the challenges. So we share our triggers, and we come up with solutions for each other. And also I attended psychosocial therapy with my social worker, whereby we did an IDP, which is an individual development plan, and that also helped a crucial role, because it made me have that self-belief in myself, because previously I had thrown in the towel. And also the most important intervention that helped me was the OST, which is the opioid substitution therapy in the form of methadone, because it helped me not to have cravings for the illicit substance that I was using at that particular moment, which is heroin, and it goes by the street name Nyaupe. I was able to function normally. Even today, I'm still functioning normally without needing the illicit substance. And also the support structure that I've been receiving in the harm reduction program has helped me a lot. Advice that I will give to anyone else who wants to change their lives is that they must live their life the way they
Thank you. And thank you to those people who have given their testimony in those little videos. Very, very interesting to see. I'm going to ask the presenters just to come back on screen. We do have a few questions. Unfortunately, we are running short of time, so we might not be able to get to all of the questions. But there are one or two that I would like to pose to the organizers. And once again, I just want to say a big thank you to everyone for their participation today. The first question that I have here is, it's quite interesting. What has been the process to start integrating more people with lived experiences in this process? And this one is for you, Dr. Day. What role do you see the usage of API with this process?
The use of, sorry, I didn't catch the last bit.
What role do you see the usage of API with this process?
API.
Yeah.
Sorry, what's API?
Yeah, I'm not 100% sure myself.
Then. Okay, good, right. Not just me then.
So,
no, I can answer the question.
She's asking that in the context of people with lived experiences. So what can we do to integrate more people with lived experiences in the process of recovery, remission, maintenance?
That's a really good question, and it's one that I'm grappling with in the UK at the moment. I think there is an alarming lack of parity of esteem for people with lived experience in terms of the expertise they can bring the process. And I think, you know, I'm a professional. I don't have lived experience. I'm sitting on the professional side of the fence, and I can see that the system isn't whole without the lived experience element of it. I think particularly for certain elements in the system, so the interfaces, when you have someone in hospital, for example, a physical health condition, you want to engage them in treatment. Speaking to someone with lived experience can often be the most effective way of doing that. Getting people to attend to try out to experience mutual aid groups like fellowship groups. Having someone with lived experience taking them there is often the most effective way of doing it. The trouble is, we find we developed an organisation in the UK called the College of Lived Experience Recovery Organisations. So trying to support organisations that started or founded by people with lived experience and give them a place in the treatment system that has, as I say, parity of esteem with other elements. I find they get squeezed out. We've had big financial cuts in the UK over 10, 12 years in our services. And the first bit to get cut is always the lived experience part, because someone else can do that job. That's, you know, we can, and they can't. I find that I think that in order to get the most from lived experience, you have to embed it within an organisation that understands that experience. Someone in early to mid phase recovery needs someone managing them who is also in recovery, I think, to get the most out of them. So that's been our process in the UK. Firstly, to try and get, I've been trying to establish a voice of you know, for people with lived experience. One of the problems being that the 12-step fellowships are fantastic, but of course they're committed to anonymity, so they don't speak out about these issues, which is absolutely fine. But there's got to be a supportive organisation that allows people with lived experience to be able to put their voice forward to the politicians and the policymakers. So that's what I've been trying to do in the UK, is get that platform, and then get we're looking to try and get the money that's spent in each area of the country on treatment systems, a certain percentage spent just on lived experience elements, which would get them that place in the system. And then the flip side of that is developing quality standards for lived experience organisations to demonstrate to commissioners when they're purchasing a good quality system.
Thank you. Thank you. Very interesting. For Dr. Scheibe, we know when agonist treatment should be started, but do we know how long should it be continued? If we consider only harm reduction goals, there is non-end for agonist treatment. This is not safe. We should offer also other paths of treatment like recovery-orientated treatments. How do you feel about that?
I think that's the prescriber's perspective, and it's very clear people should be on OST as long as they require it. So for some people it's life, and it's not without access to other services. We wouldn't expect someone with chronic diabetes to have an expectation of when their treatment should stop, and the presumption that the medication is unsafe is not true. And the science is quite clear, it works very well, and some people will need it for several years, many people chronically, some people for life. But what is clear is that if it's stopped prematurely, people's outcomes are not great.
And I think this just highlights a very important point, is that, you know, there's still this misunderstanding or lack of understanding of what OST is in this region. And I think it's very important for us as professionals within the field to educate ourselves about what is available out there and how it can assist those in need. And then my last question before we close off to Dr. Naidu, my question is about stigma. Don't you believe the shame can be useful to look for recovery?
I heard Naidu, it's not doctor, but it's fine. Stigma.
Mr. Naidu, sorry. Yeah.
Yeah, so we have an educative role to play with regards to stigma. There isn't an easy way around this. You know, it's through open conversations, both in families, in social networks, amongst professionals. It's a lack of, it's out of ignorance that stigma is there. So it's really education that is going to play a critical role in dropping that stigmatization. That's my thoughts.
Thank you. Absolutely, and I don't know if anyone else would like to add anything to any of the responses or questions that have been posed.
I'd like to add.
All right. I think we have run out of time. I do have to apologize. We didn't get to the questions that you have posed. I will try to ensure that the questions that have been posed are answered directly by the presenters who they've been posed to. We just want to thank everybody for joining us today and being a part of this, and particularly to our three presenters for the fascinating presentations and really an insight into the different aspects that are involved in substance use disorder recovery or remission or maintenance, whichever school of thought we are looking at it from. But I think the idea really behind this webinar was just to highlight the fact that, you know what, it's not a one-size-fits-all treatment process. We have to acknowledge that the people seeking our assistance are going to get different feelings from different options that are available, and that it's important for us as practitioners to understand that it's not about our perceptions, but really about focusing on the well-being of the individual who sees us in that light. So once again, thank you so much, and I look forward to perhaps revisiting this discussion at a later period. And again, thank you so much to our presenters, and have a great day further. Thank you.